Dr. Colleen Harrison graduated from Harvard Medical School. She did her residency training in Santa Rosa, California. And then we were very lucky to be able to attract her to come work with us here in Missoula at Partnership Health Center about 2.5 years ago. And during her time at Partnership Health Center, she has gotten involved with Project ECHO, which is an innovative telehealth technology program that connects primary care physicians and specialists in Seattle and throughout the 5-state WAMI region to co-manage and provide best care practice for patients with hepatitis C. So please welcome me in joining her this morning to talk with us about hepatitis C in the primary care setting.
Can you hear me okay? So I'm very happy to be talking about treating hepatitis C in the primary care setting. I'll leave this there. I work at Partnership and I have a full-time primary care practice. But as Marissa mentioned, through the ECHO program, over the past year, I've become a proficient hepatitis C treatment provider, which is a wonderful service to be able to provide to our patients, particularly at Partnership Health Center, because many of our patients have very limited access to specialists. With the new medications that are coming out with hepatitis C, more people can be treated, and I do feel it's important for some portion of primary care doctors to learn how to treat hepatitis C. It does take some specialized knowledge, and it doesn't replace the role of specialists. So there's certainly high-risk patients that I still refer to Dr. Reese or others in the community who will treat them, but there's a lot of patients that we can treat safely in a primary care setting with the help of a program like ECHO. So I have new conflicts of interest to disclose, other than all the hundreds of thousands of dollars the drug companies have given my patients indirectly in free drugs. The objectives of the talk today are, first I'm going to review the transmission and natural course of chronic hepatitis C infection, do an update on screening and diagnosis guidelines for hepatitis C, talk about how to assess a patient for treatment eligibility, and then most exciting, we're going to talk about new options for treatment of hepatitis C. If you would just hold your questions to the end, I might answer them as I go. There's a lot of information to cover. So let's start with an overview of what hepatitis C is. It's pictured here. It's a single-stranded RNA virus, and it's translated into a single polypeptide that then is cleaved into 10 different proteins. The proteins are pictured here, and these are a lot of the drug targets. There's 6 distinct genotypes of hepatitis C, 1 through 6, and then there's at least 50 subtypes as well. The virus's target is liver cells, and here is a slice of liver. You can see the classic liver lobule with this central vein, and around the edges there's the portal triads where the portal vein, hepatic artery, and bile ducts run. And then there's some connective tissue there in light pink, and the dark pink color are the hepatocytes, and that's the target cells of the virus. So when the virus infects the liver cells, it triggers inflammation. And this causes the process of fibrosis, which is replacement of liver tissue by scar tissue. The process starts in the portal areas, as you can see upper left, and then it spreads along the septa, and then you eventually get portal-to-portal bridging from one portal area to another, and that's called advanced fibrosis, or F3, down in the lower left. And then F4 is cirrhosis, the final stage of the scarring process. And there's lots of different scoring systems for fibrosis. The one pictured here is the Medivir system, and this is the most commonly used. This reflects what you would get on a liver biopsy report. You would get a score from F0 to F4, which would give you an idea of how much scarring that patient has on their way to cirrhosis. So the liver's function is compromised to a minimum until the development of cirrhosis. So the presence of clinical manifestations like a swollen belly or jaundice really indicates very advanced disease. And not long ago, we thought that fibrosis was irreversible. But we now know that there's a dynamic process of fibrinogenesis and fibrinolysis. And there's been some really encouraging studies recently showing that successful hepatitis C treatment can lead to improvement in fibrosis, although not complete reversal. So this chart shows U.S. data of how people get hepatitis C currently. Transmission is so-called blood-to-blood, so it does require direct exposure to infected blood through the skin. And in developing countries, unfortunately, hepatitis C is still most commonly transmitted by healthcare, so infected needles or blood transfusions. In our country, as you can see, the most common form of transmission is injection drug use, IV drug use. But thinking about how Hep C is transmitted does help us decide who needs testing and who needs screening. So just to go through the risk factors, So IV drug use first and most common. Very efficiently passed in IV drug use. So about a third of young IV drug users are Hep C infected, but those who have used IV drugs for over 30 years, 98% of those people are infected. So very, very high prevalence. And the virus can stay alive for 63 days in a vial. Very infectious. It's also possible to get Hep C through intranasal drug use. So there was a study of intranasal drug users that are Hep C positive that showed high prevalence of blood in the nasal secretions, and then a certain percentage, about 13% of those nasal secretions actually had the Hep C virus in it, and they could isolate that and show that it could be spread from straws. Other exposures, homemade tattoos and piercings. Occupational exposure, which is relevant to all of us here, so a needle stick with a contaminated needle. Transfusions prior to 1992 when we started to screen the blood supply. Sharing items with a Hep C person that might be contaminated with infected blood, so razors, toothbrushes. And then there's some high-risk groups that you'd also want to screen. So HIV positive patients, patients who've been incarcerated. You would also screen somebody if they did have elevated liver enzymes or liver disease, but you didn't have another good cause or reason for it. And lastly, there's a large group that should be screened once in their lifetimes, and that's anybody who has a date of birth between 1945 and 1965, so the sort of baby boomers. And that's because there's a high prevalence, it's the highest prevalence cohort, and most of the people in that cohort don't know that they're infected. They were infected in the 1970s and 80s, a long time ago, maybe some brief experimentation with drugs. And so that group really needs to be screened. We need to watch out for that in the primary care setting, for sure. So sex is a pretty inefficient mode of transmission for hepatitis C, but certain groups do need to watch out. There was a study in 2013 in the journal Hepatology that confirmed that monogamous heterosexual couples do not pass hepatitis C efficiently between them. So about 500 Hep C positive patients and their partners were studied over a period of years, and it was found that the transmission by sex among these couples was 0.07%, so 1 per 190,000 sexual contacts, very low, and we don't counsel those patients to use condoms or change their practices. However, there are groups that are at risk for sexual transmission at a higher rate, and that includes co-infected patients who have HIV. This increases the viral load of Hep C and the infectivity. Also, anyone who has a current anogenital infection. And then there's certain sexual practices. The most strong risk factors for transmitting Hep C would be receptive anal sex or sex while high on methamphetamine. So rough sex where there's more possibility for blood exposure. So according to the CDC, of every 100 people that is infected with hepatitis C, 75 to 85% will get chronic hepatitis C, which means about 20% actually clear the infection on their own. And this generally happens in the first few months, but it can happen for up to a year after the infection is, after they get the infection. 20 to 30 about 100 people will go on to develop cirrhosis, and approximately 5% will die from the consequences of their chronic infection. whether it be from liver cancer or the complications of cirrhosis. So even though many will not get cirrhosis, chronic hep C infection is the leading indication for liver transplant in the United States. And there's been some cost analyses done with the new medications that show that it is cost effective to treat everyone with hepatitis C due to the high cost of caring for people who require liver transplants or have cirrhosis. And importantly, a person who clears the virus spontaneously is still at risk for getting hepatitis C again if they get re-exposed. So having the antibody does not confer any immunity to the infection, unfortunately. The prevalence and incidence of hep C is hard to estimate because acute hepatitis C is oftentimes asymptomatic. So less than 1/3 of people actually have symptoms when they first get hep C, and it can be a really nonspecific flu-like syndrome that might be misdiagnosed. Early on, in the first 6 months, the viral load, which is one of the tests for diagnosis, may be negative and positive. It can fluctuate. So with all this taken into account, in 2007, the CDC reported 849 confirmed cases of acute hep C, but they estimated 17,000 new cases that year, taking into account asymptomatic infection and underreporting. And in terms of the prevalence, it's thought that over 3 million Americans have chronic hep C, many of whom don't know it. And as I mentioned before, that most prevalent cohort is now far from their exposure and needs to be reminded about screening. They don't have the obvious risk factors. So there's two types of tests for hepatitis C. There is an antibody test, and there's also a direct viral load, which tests the actual HCV RNA. So the antibody we use for screening, it has a 98% sensitivity. So if a patient is screened for the antibody and they get a negative, you can assume that that's a true negative. That's a good screening test. The only exceptions to that would be if somebody has had exposure or possible exposure to hep C in the last 6 months, because the antibody does not reliably show up until about 6 months. About 97% of people exposed will have the antibody by 6 months later. So that's the window period. The confirmatory test is what we call the viral load, the direct RNA test. And this is the test that you need to actually confirm that somebody has chronic infection, that they're not one of that lucky 20% that cleared the infection on their own. There is also a point-of-care test in the clinic that has a little bit lower sensitivity and specificity, so I won't talk too much about that one. The person who gets the positive antibody and you get the confirmatory test and it's negative, so they have no viral load, it's undetectable, you can assume that that person cleared the infection and does not have chronic hep C. And the exceptions to that case, again, would be that window period. So if they've had a possible exposure in the last 6 months, you would want to repeat that viral load 6 months later to make sure that they don't have chronic hep C. There are, as I mentioned, 6 genotypes. Genotype 1 is the most common in the U.S. About 70% of people have genotype 1, and actually in the world is the most common. And then followed by genotypes 2 and 3 here in the U.S. And we don't get very many 4, 5, and 6. So let's say you diagnosed somebody. They had a positive antibody, you confirmed it with a viral load, and you also got a genotype. The next step is to educate the patient about this new disease that they have. So I talk to patients about any hepatotoxic drugs, including Tylenol, and I discuss with them alcohol and marijuana. So if there is any chance that a patient has advanced fibrosis, they really should avoid alcohol completely because even one drink can decompensate the liver. And interestingly, marijuana has been shown to accelerate the progression of cirrhosis when it's used daily. So there's been several studies to show this, and you can see on this graph that whether or not the patient uses alcohol, those who were daily cannabis users in the green had a much more rapid progression of their cirrhosis, of their fibrosis, and it's thought to be due to an inflammatory reaction from the marijuana in the liver. You also want to make sure that hep C patients are immunized against hep A and B, so it just prevents another hit on the liver. I educate patients on how hep C is transmitted and how it's not transmitted so they can be careful in the right settings. So healthcare settings, tattoo parlors, high-risk sexual activities. You want patients to know how the Hep C can be prevented from spreading to other people. And then it's important also that they know that it's not spread by kissing or sharing food or utensils, because there's a lot of stigma around having any chronic infectious disease. I talk about symptoms. Many people don't realize that chronic Hep C can cause fatigue or chronic pain, very nonspecific symptoms. And of course, I want the patient to know what the symptoms are of cirrhosis so they can keep an eye out for that and let me know if they notice anything. And finally, most exciting, we get to talk about treatment options and eligibility. So it's a decently long visit when you first diagnose somebody. So in addition to the patient education, you need to do a thorough assessment. And the point of the assessment of a newly diagnosed Hep C patient is to find out what is the severity of their liver disease and what is the rate of progression. So I start with a thorough history. First, I want to estimate the duration of disease based on when they had the risk factors or the exposures, and also any previous Hep C testing they may have had. Also important is to ask about a treatment history. So many patients have tried treatment in the past and failed, and were they a null responder, so their viral load didn't budge, or were they a partial responder, or did they relapse after treatment? Those can all be important when you're planning treatment. So a good history of previous Hep C treatments. Then I ask about symptoms. As I said before, if you find that a patient has some nonspecific symptoms that may be due to Hep C, that's a reason why treatment might benefit them. And after history, I do an exam. So in the exam, I'm really focusing on checking for signs of cirrhosis. Compensated cirrhosis means the liver is heavily scarred but can still perform most functions, whereas decompensated cirrhosis means the liver is excessively scarred and unable to function. Here's an example of that. So people with decompensated cirrhosis often develop complications from portal hypertension. So you can see that Homer here has some ascites or swelling of the belly, spider angiomata, which are swollen blood vessels near the surface of the skin. You can get edema and muscle wasting. And cirrhotics also lose the ability to metabolize their ammonia to urea. So this is why they can get some confusion, encephalopathy, and jaundice, because the liver can no longer process bilirubin. So in the physical exam, I'm looking for those. And then I need to check for specific extrahepatic manifestations of Hep C. So because of the inflammatory reaction that hepatitis C can cause in the body, there's many different associated conditions that are important to know about. I think most importantly is glomerulonephritis, a kidney disease that can lead to kidney failure. Another big one is essential mixed cryoglobulinemia. So looking for cryoglobulins, these can lead to, these are abnormal proteins that flow around in the blood and can accumulate in different tissues. They can lead to vasculitis or chronic pain. There's several skin conditions, including porphyria cutanea tarda, which is an abnormality in heme production that can lead the skin to become very fragile and blister. Also lichen planus, which causes white lesions on the skin. I'll show you the patient who had that. After the exam, I move on to labs, and labs are also assessing for fibrosis. It is true that most patients with Hep C have an elevated AST and ALT, but not all of them. And a normal ALT does not mean that there's no fibrosis. So the liver enzymes really are not an assessment of fibrosis. What are more helpful are platelets, total protein, and albumin, which can all be low if the liver is unable to make proteins. And elevated prothrombin time and bilirubin are also signs that the patient might have cirrhosis. There's also special lab tests that are specifically non-invasive tests trying to assess the level of fibrosis. Some of these are simply calculators that you can use your basic metabolic panel and CBC. Others are special tests you have to order. So there was a prospective clinical trial in 2007 that compared about 6 of these so-called non-invasive fibrosis assessments and found that the best of them can predict the presence or absence of cirrhosis with 90% accuracy. So the study did confirm what other smaller studies have found, which is that These tests are really good at detecting either no fibrosis or advanced fibrosis, but they're not great at distinguishing the grades and stages in between. We're just going to look at a couple of these. So pictured here are the APRA score and the FIB-4 score. So these are two calculators that you can use with just basic lab results. And if they come to a certain number, a high number basically, for both of these, they each have a cutoff, they are fairly specific for advanced fibrosis or cirrhosis. They do have limited sensitivity, but in certain cases it's a lot easier to rule in cirrhosis. The other test that I use really commonly is called FibroSure, or Fibro test in Europe, and it's a simple blood test. It measures 5 elements in the blood, and it actually gives you a score that correlates with what you would get with a biopsy score. So you get an F0 through an F4 score. You actually get an A score for the level of inflammatory activity. And there has been a recent test of the FibroSure that suggests that it's, in many cases, a good substitute for a liver biopsy. Another one that's not as widely available is the FibroScan, which is a machine that sends a vibration wave through the liver and detects fibrosis in that way. So these are all great non-invasive tests, but biopsy is still occasionally needed. So I would consider a biopsy if I need to know more exactly the level of fibrosis in order to decide on which treatment or how long I'm going to treat a patient. Or if there's a disagreement between the non-invasive tests, between one and the other, or between the ultrasound, perhaps it has a large screen suggesting maybe some advanced fibrosis, but then the other non-invasive tests or the labs don't point to cirrhosis. So if there's not a clear picture one way or the other, it's still indicated to get a liver biopsy, but we're definitely doing a lot less of liver biopsy now than we used to, which is great. I did want to mention too that besides just planning for Hep C treatment, really knowing whether or not somebody has advanced fibrosis is important for screening for hepatocellular carcinoma, so liver cancer. So anyone who has cirrhosis, and even somebody who has F3, which is advanced fibrosis, is at much higher risk of liver cancer. And it's been shown that these patients should be screened every 6 months with an ultrasound of their liver. You can see here that in the screened group, the large green is that those were all diagnosed at stage 1, whereas the other side you can see that the control group that did not have screening for liver cancer were diagnosed at stage 3 cancer. And then that does translate to better mortality outcomes. So the blue line on the top is the screening group, and that's the survival after diagnosis. So definitely really important, and I just want to emphasize that even after hepatitis C treatment, you're not done with the patient. If they do have F3 or cirrhosis, they need lifelong screening for liver cancer. So you've assessed your patient. Now you need to decide when to treat them. This is a decision that's changed quite a bit over the last few years as treatments have become more effective and more easily tolerable. The purpose of treatment is to prevent cirrhosis and its resulting complications, such as liver cancer, as I mentioned. So because of the new medications, the official guidelines, which are released from the American Association for the Study of Liver Diseases and the Infectious Diseases Society of America, are to treat all chronic Hep C patients. And this recommendation is given a Class 1 Level A recommendation, meaning that there's good evidence behind it. However, we all acknowledge that we have limited resources, so we need to prioritize who we're going to treat first. We want to treat first the people who are going to benefit most, but also perhaps the people who may impact further transmission rates the most. So when you're deciding with your patient whether to treat them, you want to ask yourself whether or not their hepatitis C is ever likely to become symptomatic. In a patient with very mild disease and no symptoms, they may opt to wait for treatment. In a patient of a certain age who does not have cirrhosis and is not likely to ever progress to cirrhosis, may not need to be treated. They may not actually get any benefit from it. Those who do need to be treated, the highest priority are cirrhotics or those with F3, advanced fibrosis. Also in that highest priority group are people who have extrahepatic manifestations, like I mentioned, kidney disease, cryoglobulins. And then liver transplant recipients are also in the highest group. The next highest group, still high priority, but one down, are anyone who is at increased risk of a more rapid progression of their Hep C. And this includes patients who are immunocompromised, including diabetics or co-infected patients with HIV or Hep B, and patients who have severe symptoms, maybe debilitating fatigue, and other patients who have liver disease, so hereditary hemochromatosis, something like that. The third group of high priority is more controversial, and this includes patients who are at risk of spreading Hep C. So this is active IV drug users, patients who are incarcerated. There is theoretically a benefit, for example, of treating a whole needle-sharing group and preventing the spread of Hep C, but it's controversial and difficult because these are also the patients who are at risk of getting reinfected. As I mentioned, once you're treated, or if you have the antibody, you still can be reinfected even with the same strain of hepatitis C. So it's a little more complicated. So just to review, when you're talking with your patient, deciding when to treat, think about the risks of delaying the foregoing treatment. Think about their likelihood of getting re-exposed to hepatitis C. Check for extrahepatic manifestations. Think about the ability to tolerate treatment. This used to be a really big deal. It's still relevant because many of the new regimens include ribavirin, which can cause severe anemia, and that can be troublesome for people with severe cardiac or pulmonary disease. So still an important consideration. And then think about their ability to complete the treatment without interruption. Similar to a course of antibiotics, if you stop your Hep C treatment in the middle, there is a risk of developing resistance, even to some of the new drugs that have a higher barrier to resistance. So if a patient's about to move, if a patient has unstable mental health, if they are going to run out of money for coming in for labs and appointments halfway through, it's not the best time to treat their hepatitis C. Rarely is it an urgency to treat hepatitis C. You want to really choose the best time in the patient's life when they're really stable. A couple of special cases for Hep C. I wanted to mention Hep C in pregnancy. As I alluded to before, Hep C can be transmitted vertically from a mom to the baby, and it's not clear if it's during pregnancy or during delivery. Studies suggest that perhaps both are possible. Unfortunately, we don't have any ways of reducing vertical transmission. There are a couple of factors that increase the rate. So co-infection with HIV or anything that increases the viral load for mom, that increases her infectivity. Also, prolonged labor has been shown to be a risk factor. So for your pregnant patients, you want to screen only if they have risk factors. It's not a universal screening. And if they have a positive antibody, of course, you have to confirm the viral load. You don't really know if they have chronic hepatitis C. Many obstetricians recommend that we avoid a fetal scalp method, not evidence-based, but the other recommendation is to avoid prolonged ruptured membranes, and that's also a little vague of how to do that. It is not an indication for a cesarean, so it does not reduce the transmission to a cesarean versus vaginal. And then breastfeeding is okay. As long as the woman doesn't have bleeding, cracked nipples, she can breastfeed safely. In terms of testing the baby, there's a couple of options. One is just using the antibody test. It requires waiting until 18 months so the mom's antibodies are cleared, and many people are antsy to know before that. So you can actually test the direct RNA level at the first well-child visit at 1 to 2 months, and then that requires a repeat 6 months later to confirm. It is important to take vertically transmitted Hep C seriously because it can be a very rapid or a very slow progression. It varies quite a bit. And although the new medications are not approved for children, there are trials that use each of the new regimens that is out for adults, and patients can get into those trials and get treated while they are children if it's important for them to do so. So definitely important. The next special case I wanted to talk about is co-infection with HIV. You can see here on this graph, the co-infected patients are the beige. HIV accelerates Hep C disease progression. So end-stage liver disease and hepatocellular carcinoma which both are resulting from chronic Hep C infection usually, are now leading causes of death not attributable to AIDS in HIV-positive patients. It's a really important population. Because of this rapid progression, any co-infected patient is a priority and indicated to treat their Hep C. Even if they have F0, no fibrosis, they should be treated. And ideally, their HIV would be under control and their viral load undetectable before they start the Hep C treatment. There are, as with most HIV medicine, there's a lot of medication interactions, and so I put up this website. I'll show it again at the end. You can plug in the patient's HIV meds and their Hep C meds and see what the interactions are. Most of them are not contraindications, but cautions. With a lot of the medications, we can get a high bilirubin, we can get decompensation in cirrhotic patients. So really important to coordinate care between the HIV provider and the Hep C provider. I listed a few of the trials. There's less trials in co-infected patients. Many of them didn't include cirrhotics, and some of them found a lower cure rate. Others found comparable cure rates in HIV patients. So a brief history of Hep C treatment. It's a really exciting story. Hep C was first discovered in 1989, and in the 90s, we treated it with interferon. Some of you may know interferon is almost like chemotherapy. It's an injected drug. Interferons are actually molecules that our body makes in reaction to a pathogen, so a virus or bacteria. But these are formed into drugs and injected and very difficult to tolerate. They also were not very effective. So genotype 1, which most people have in this country, had about a 9 to 10% cure rate with this treatment, very low cure rates. In the early 2000s, we added ribavirin, which is another non-specific antiviral. It prevents viral replication. It has its own set of side effects, and it did increase the cure rates in genotype 1 to about 50%. But still, 80% of patients who were taking that regimen had serious adverse side effects, and less than half could complete the treatment. In 2011, the first major breakthrough was the first generation of protease inhibitors that were used in conjunction with interferon and ribavirin in what we call triple therapy. And these did increase the cure rates, again, in genotype 1s between 65 to the high 70%. But they were expensive. They have a very low barrier to resistance, and it's still really difficult to tolerate, especially in cirrhotic patients. About half of cirrhotic patients suffered serious adverse effects, and 2 to 3% died during treatment. The cure rates, however, went way up. And then in late 2013, which is kind of when I came on, right at the perfect time, we got the second generation of protease inhibitors, sumeprovir, but more importantly, sofosbuvir, which is Sovaldi. You may have seen this in the news. And this is a new type of medication. It inhibits the polymerase that the virus uses to replicate its RNA. And its target is a highly conserved section of the virus. So it has a pan-genotypic action. It's good for all genotypes. It also has a very high barrier to resistance. So this was a really big deal. Still, at first, for genotype 1s needed to be used with interferon. So a lot of genotype 1s waited still to be treated with this medicine, even though the treatment was now shorter and the cure rates were up to 90% in genotype 1s. Sofosbuvir also introduced the first all-oral treatment for genotypes 2 and 3. And this was also really exciting because a good portion, about 30% of those infected in the U.S. have genotypes 2 or 3. And sofosbuvir can be used just with ribavirin, so no injection and no interferon necessary. And the cure rates are between 90 to 100%. So really exciting stuff. But then, perhaps even more exciting, was late 2014, so very recently, sofosbuvir was combined with ledipasvir, which is a different protein inhibitor, NS5A. This is a combined fixed pill called Harvoni, and you may have seen this also in the news. So this came out, and this is the first all-oral regimen for genotype 1s. So big deal. A lot of people who have been waiting for a long time were ready to get treated. The cure rates are 95 to 100% with this medication. Shortly after, a competing product came through from AbbVie. So Gilead Sciences is the one that released both Sovaldi, sofosbuvir, and Harvoni, that combined medication. And then AbbVie is a different company which has its own polymerase inhibitor that has a slightly different mechanism of action. that is combined with a protease inhibitor, another NS5A, and a booster. So it's actually a combination of 4 drugs, and it is often used with ribavirin. So that's called the Viekira pack. And those two were the big news at the end. I show this not to get into the details of which treatment a patient needs, but there's flow sheets that give you the recommendations on what a patient should be treated with and for how long. So this depends on several factors. One is whether or not the patient has had treatment for hepatitis C in the past. So if they haven't, they're called treatment naive. They're a little easier to treat. If they have failed treatment in the past, they're called treatment experienced. And it's sometimes helpful to know actually whether or not they responded in the past. The genotype is important, and in some cases, particularly with the Viekira pack, the subtype, so 1A or 1B, can be important. The pre-treatment viral load is sometimes impacts your treatment. So if the viral load is really low, that might allow you to treat for a shorter amount of time. And then very importantly, whether or not the patient has cirrhosis. So patients with cirrhosis in general don't do quite as well and oftentimes require a longer treatment course. So those are all important things that you would take into consideration and figure out exactly what treatment to use. I do want to mention that decompensated cirrhotics are the hardest to treat, not only because they have a harder time tolerating treatment, but they also have lower cure rates. But so in the studies with decompensated cirrhosis, the new medications still have cure rates in the high 80%, so it's still really good. And many of them actually show improvements in their MELD score after treatment. So the MELD score is a good predictor of mortality, and these patients can see improvements in their bilirubin, their albumin, their platelet counts. And decompensated cirrhotics are patients that in the past have been also the most challenging. So that's exciting stuff. I mentioned before that the American Association for the Study of Liver Diseases and the Infectious Disease Society of America, are the ones that release the guidelines and the recommendations for treatment. So I'm going to go through the first-line options for a treatment-naive patient. So they've never had hepatitis treatment before. I did include here the grading system. So a class 1 recommendation, it means that there's general agreement that the treatment is beneficial. Class 2 means there's conflicting opinions or conflicting evidence. And then level A means there's multiple randomized controlled trials behind a recommendation or meta-analyses. And level B means there's only one single randomized trial or perhaps non-randomized studies. And then I also included the cure rate. And cure, when it comes to hepatitis C, means SVR, so sustained viral response. It's the viral load 3 months after they've completed treatment. It is true that some patients will relapse later, especially in cirrhotics. So some people do test at 6 or 12 months if the patient is a cirrhotic. But generally, if a patient has an undetectable viral load 12 weeks after completing treatment, they are considered cured of their disease. So that's where that number comes from. I also wanted to mention before jumping into medications that I do some pre-treatment education because these are really expensive medications. They're going to be hard to replace if somebody drops them or loses them. And I also, for that reason and also for the resistance factor that I mentioned before, I really want the patients to have a good system to help them remember to take their pills every day, whether it's a pill box or a calendar or a phone alarm. I really encourage that. I push that hard. So let's talk about Harvoni first. Harvoni is one of the first-line treatments now for genotype 1. We mentioned it before, and it is really well tolerated. You can get some headaches, nausea, fatigue, but less than 20% of patients get these side effects. And it really doesn't have a lot of drug-drug interactions. One important one is acid blockers. And a lot of people are on PPI or they use Tums, so you have to counsel really carefully that this medication requires stomach acid to be absorbed. Another first-line option is the Viekira pack that I mentioned before. It also has great cure rates. It does have more drug-drug interactions that you have to watch out for. And it has there's actually 4 different specific ways that you use it with and without ribavirin, and for different periods of time, depending on if the patient has 1A or 1B and whether or not they have cirrhosis. A little more complicated. Different insurance companies, and interestingly, are kind of choosing one or the other and making a deal with the companies for discounts up to 30%. Some insurance companies are covering both, but these are both the main first-line options. I will, just for completeness, show that older regimens are still options in the recommendations, but they come with a lower grade recommendation. There's been a lot of press about the 8-week treatment, and there is an 8-week treatment, but it's really only for a specific subset of the population of Hep C patients. So it was not studied separately in a randomized controlled trial, but in post-hoc analysis, they found that patients who started out with a low viral load, a relatively low viral load, did just as well in terms of cure rate at 8 weeks of treatment, just doing 8 weeks of treatment as doing 12 weeks of treatment. So actually, insurance will only pay for 8 weeks in those patients. So that study did not include cirrhotics. So this is for non-cirrhotics, but it is pretty exciting. I have several patients who are doing just 8 weeks, which is the shortest ever for hepatitis C treatment. Genotypes 2 have had this all-oral regimen available for well over a year, and it's a combination of sofosbuvir and ribavirin. They're not fixed combined pills, but you just prescribe both of those. And as I mentioned before, ribavirin does cause anemia, especially in cirrhotics, but can cause anemia. Not everybody, but you do need to do labs, and there's specific times when you need to do labs. And you want to check frequently at the beginning. You want to catch anemia early and reduce the dose of ribavirin. As long as that's done and treatment is not interrupted, it does not affect the cure rates. But if it's not done and a patient gets so anemic that you have to interrupt treatment, that can really affect the cure rate. So that's one important thing. Genotype 3 is the most treatment resistant and difficult to treat. It's also the most aggressive type of hepatitis C. There are good cure rates with 24 weeks of sofosbuvir and ribavirin, and that is pretty well tolerated, especially by non-cirrhotics. But there is much better options coming down the pike, some pan-genotypic, shorter options with better cure rates. I just put these here for completeness, but we don't have a lot of genotypes 4 through 6 in the U.S. I wanted to mention cost of treatment. This is a really big consideration with our population at Partnership. The medications, of course, cost a lot. That was probably as big in the news as the medications themselves, so it's how much they cost. Sofosbuvir, $1,000 a pill, Harvoni, over $1,000 a pill, so you can rack up, over $100,000 very easily. There are medication assistance programs through the companies themselves. There are copay assistance programs for patients with high copays. There's something called the Patient Access Network Foundation, the PAN Foundation, for patients with high deductibles. There are other costs for patients that don't have insurance. So office visits are a cost. At the beginning, when you're assessing their level of fibrosis, you might need an ultrasound. I often get that to help me figure out whether or not they have cirrhosis. And that's over $500 plus a reading fee. And then labs alone can easily rack up $1,000 or more. The viral load and the genotype are very expensive labs to get, and even the FibroSure is almost $100. So it's just important to think about up front. For those who do have insurance, getting insurance authorization is quite a learning curve for providers. So as a primary care provider doing that, at first, you just have a lot of information that you have to give the insurance company. And a couple of the areas where I had hiccups at the beginning were that many insurance companies require a specialist be taking care of the patient and treating their Hep C. However, they do allow primary care doctors to treat Hep C if they are using a program like ECHO that we talked about early on. So I just write that in on the prior auth, and that's just fine. Also, sometimes they require 2 separate viral loads 6 months apart, and as we talked about before, according to the CDC as well as the ECHO team, if a patient hasn't had any recent exposure to Hep C, they don't need 2 separate viral loads 6 months apart. And so I usually just write in the support for that. But there are a lot of hoops to jump through at the beginning. It gets easier. Just real quickly, I wanted to mention that there are a lot of Hep C drugs in the pipeline. So just to give you an idea, in the last 16 years of drug development for Hep C, 77 Hep C medications failed in clinical trials. 12 medications were approved. Right now we have 75 Hep C medications in trials, in development. So a huge explosion. And many listed here, especially the one in bold, is going to be the one to keep a lookout for. Sofosbuvir combined with GS5816 is likely to become our first pan-genotypic, all-oral, fixed dose, 1 pill per day, coming out from Gilead. We'll have information on that at the end of this year. The race is now to get even better cure rates and even shorter treatment duration. There's even a medication in early studies that is a single dose. So really exciting stuff. The resources I used and that I would point primary care doctors to if they want to get into hepatitis C treatment. First, the University of Washington is wonderful. I used a lot of their graphics in my presentation, and they have an online hepatitis C course that's shown here. You can use that as a reference. The guidelines, as I mentioned, come from hcvguidelines.org, and that is kept up to date, and that's where I got the treatment naive guidelines we went through. For patients, you really want to point them to the right place, because even online, where you would think things are kept up to date, a lot is outdated, even online, because Hep C is just moving so quickly. So hcvadvocate.org is a great website, and hepmag.com, although it's kind of commercial, is a good website that patients can use to find out what is coming down the pipeline and when. And drug interactions, I just put that there too. I also use several other sources. So let's see, do we have time? We have a little bit of time for questions. So, question. Yes?
The new guidelines discuss, I just anything about interferon. Is there still a population where you use the old electrical therapy, or is there a strict indication where you have to use that for medications?
Good question. So the question is whether or not there's any indications for using interferon for some subset of populations still. The interferon regimens are still they're still approved, they're still in the recommendations as like second and third line. I don't think there's very many cases in which we would use interferon, but there might be cases where you would go back to sofosbuvir, for example, or the first generation of protease inhibitors if a patient has developed resistance to the newer medications. You might end up bouncing back because a lot of those newer medications, new and old medications have a low barrier to resistance. So if a patient had their first treatment and they started later and developed resistance, they might actually be eligible for the older treatments. But a lot of those are becoming completely irrelevant. Even the first generation protease inhibitors, which when they first came out were so expensive, they really only had a lifespan of about 2 years. And the sofosbuvir and sofosbuvir, we don't use those very much anymore.
Can you explain Project Echo, how that works? Is that a typing thing?
Yeah. I'm a really big fan of Echo. I'm actually going to be doing it when I'm in Colorado through a different hub, which is out of the University of Utah. So it's generally based out of an academic medical center, and it's a panel of experts, different types of providers, so a hepatologist, infectious disease, mental health, there's always some students in there, but really wonderful specialists in particularly hepatitis C treatment that once a week conduct about an hour-and-a-half session. It's a video conference, so we hook up our own camera and microphone, and they can see us. We can turn on and off the microphone. They give us a short didactic with a PowerPoint presentation. One of the experts will give it, and it just varies, but it's always very up-to-date and super relevant. And then we go through case presentations, and I learn as much from other people's case presentations as my own. But it was very instrumental in me being able to treat hepatitis C, because when I started, despite some continuing medical education, I still really didn't feel comfortable making my own treatment decisions. So I would present every case, and they are sticklers for details. You present a very detailed case to them, and they are very thorough, and they keep up with our patients. They want to know what the viral load is and what the labs are at 2 weeks and 4 weeks, and update presentation. So it's a great consult. They can't get their hands on the patient, that's true, but it really provides a level of specialist care that wouldn't otherwise be available to primary care doctors.
What kind of dosing is this? These $1,000 pill, is it a pill a day or is it multiple?
It's pretty simple. The Harmonia is 1 pill a day, and it doesn't vary. The ribavirin is weight-based, so there's a couple of different possible doses. But the Vicura pack is also just a fixed dosing. And, you know, the drug companies are trying to make it as simple and most easily tolerable possible. I think for a lot of us, you know, whatever, 3 pills, 1 pill. But they are going more towards a fixed dose, single pill regimens. Compliance, it does. Yeah. Do you have another question?
I was just wondering about post-exposure prophylaxis for healthcare workers. Is there any indication for that with these meds, or do you still wait for such viral?
That is a really good question. So, you know, traditionally there hasn't been any effective, at least, you know, you can't use IVIG or immune globulin because the antibodies are not effective, so there hasn't been a good post-exposure prophylaxis. I don't know, actually, whether, I don't know if Dr. Reeson knows this.
Yeah, no, I mean, at this point, there is no indication for post-exposure prophylaxis. So what we do is we follow someone who's had a high-risk exposure very carefully and try and identify those people quickly before they do the break. But the natural history of hepatitis C is spontaneous clearance and perhaps up to a quarter of people. But we now know that, again, with these new drugs, it's pretty easy to treat, especially if you treat people relatively early. So if they fail to clear the virus by 6 months after the exposure, then that's usually what we're going to get off.
Just real quick before I take the next question. Yeah, that just also reminds me. So I was kind of curious if with these new medications being so easily tolerated, being able to be treated a pregnant patient, and sort of along the same lines, if a patient has hepatitis C, it's not generally urgent to treat them. You can wait, and now the treatments are so effective and well tolerated, you can wait till the right time to treat them. So I think even in that post-exposure situation, it's now much more treatable. It's almost a different picture than before. What was the question back there?
Yeah, my question was about checking the viral load in pregnant patients that are antibodies positive. What's the rationale and the cost?
Yeah, so checking the viral load in a pregnant patient is really just to confirm that they have chronic hepatitis C. Currently it's not recommended to treat them during pregnancy. So if they had a negative viral load and they cleared the hepatitis C, you wouldn't need to treat the baby and you wouldn't need to worry about it later on, like during, you know, when you're managing the delivery. So it's really just to confirm chronic Hep C infection.
I would just add that I think even though we don't do anything different, it's somewhat helpful to the patient to know if it's a high viral load, it's a higher risk of transmission, whereas if it's a low viral load, it's much less. And I just think for their own state of mind, sometimes it's helpful to have that information.
It might be the only time they have insurance too, so that'd be helpful to get them.
But well-controlled HIV really reduces the risk of hepatitis C transmission very period. So if these people are co-infected, then getting on HIV therapy.
Last one.
You can agree with me.
You just from a workup point of view, manual point of view, when you're doing the initial Hep C workup, do you check for Hep A, Hep B immunity, or do you vaccinate everybody?
It's a great question. We do check. So getting that hepatitis panel is kind of part of the labs we get at the very beginning when we get, I mean, sometimes that's how they actually get the positive antibody, but that's important because some patients will have had the whole series of Hep A, B vaccinations and it didn't take. Like they won't have the antibodies, and in that case, you actually repeat the whole series. Other patients will need just a booster, and then some patients just have the immunity from before. But a lot of people are not immunized against Hep B. We are because we're healthcare workers, so that's a big one. Even if you're not going to treat the Hep C right away, you would want to get them vaccinated right away. So, and it is.